mute. The background noise can make it really hard for everyone to hear. We will have time for questions at the end of the webinar, and so you're welcome to text your questions into the chat box at the bottom of your screen, or come off mute after the presentation and ask your question, and we'll do our best to get them all answered before the end of the webinar. Also, just a third thing, please be on the lookout for an email after the event. You can really help us by completing and returning the survey. This gives us valuable feedback about this event and any of our future webinars that we're planning. The Global Alzheimer's Platform Foundation is a nonprofit organization that was established in 2016 with the goal of seeking to speed up drug development for Alzheimer's disease, and we've recently added Parkinson's disease to our network. We continue to spread the word on the importance of all of this research. We now have a network of over 80 member sites in the US and Canada that work on both PD and/or AD, and we support those sites with their efforts. All of these sites have to meet certain criteria to be part of the GAP network, and we really encourage you to go to our website after the webinar and see which site is closest to you. Now it's my pleasure to introduce our speaker for today. Dr. Valory Pavlik is an associate professor at the Department of Neurology at Baylor College of Medicine and associate director for research in the Alzheimer's Disease and Memory Disorders Center at Baylor College of Medicine in Houston, Texas. She has spent over 20 years as a clinical epidemiologist studying the effects of behavioral lifestyle interventions on cardiovascular risk, factor control in underserved populations, as well as the effects of cardiovascular risks on cognitive function. She's collaborated with Alzheimer's disease clinicians and neuropsychologists to analyze risk factors for rapid progression of cognitive and functional decline in patients with AD. As Associate Director for Research in the Alzheimer's Center at Baylor College of Medicine, Dr. Pavlik oversees the implementation of randomized trials of investigational agents to prevent or treat AD. She currently serves as the Houston site principal investigator for the US Pointer study sponsored by the Alzheimer's Association. This trial seeks to compare two different approaches to encouraging lifestyle change to reduce the risk of cognitive decline in older individuals. As part of her involvement in clinical trials, Dr. Pavlik has conducted cognitive and behavioral ratings and regularly participates in weekly diagnostic and case management conferences conducted by her site clinicians. Her bibliography includes more than 75 articles and commentaries in peer-reviewed journals. We at GAP have worked closely with Dr. Pavlik and her study team on several important AD studies, and I'd like to turn the talk over to her at this time. Dr. Pavlik? Are you able to load your slides, or would you like me to show them?
Yes, no, you're going to have to show the slides because of the password issue.
Okay, no problem. So I'm up. Let me pull those up. And okay, are you able to see them?
Again, I'm not online, so I'm looking at my slides, and I'll move through them, and I'll give you a signal when to change.
Okay, that sounds good.
All right. Well, thank you to the Global Alzheimer's Platform for inviting me to give this talk, and thanks to everyone who's joined as part of the audience. Let me start with a disclaimer to point out, as you heard from my biography, that I'm not a sleep medicine doctor nor a sort of sleep therapist, but I come at this topic very much as an epidemiologist who has for years studied the role of sleep problems in cardiovascular disease and also as a risk factor for cognitive impairment. And as, again, I want to remind everyone that in my experience, I've administered many behavioral questionnaires to study participants and have sort of experienced firsthand the difficulties that many patients with Alzheimer's experience because of sleep problems. So I'll begin to talk now. If we can go to the first slide after the title. So the slide is going to start with sort of a regular garden variety insomnia and other sleep problems in normal populations, and then we'll shift a little bit more to sleep problems as a feature of Alzheimer's disease. So in this slide that's labeled sleep cycle, there's a sort of graphic presentation of the architecture of sleep. So on the left, you see the various cycles that somebody goes through as they sleep. So one sleep cycle consists of a stage 1 with very light sleep, stage 2 where the breathing slows. This is the longest phase of the cycle. Then a transition in stage 3 into very deep sleep that has these delta waves. You see on the top the way the brain waves change as people go through these cycles. And then from very deep sleep, the individual transitions to rapid eye movement sleep, otherwise known as REM. And this is the cycle of sleep where dreaming occurs, and it's the cycle that's sort of necessary to have a completely restorative sort of episode of nighttime sleep. So on the left, you see what a complete nighttime of sleep would look like. It would consist of several of these individual cycles going from light sleep down to very deep sleep and then through rapid eye movement. And the number of cycles, the duration of the cycles may vary from person to person and even within person from night to night, but that is what the components of sleep are. And these are the features that are measured when you go for an overnight sleep study. All right, so the other thing we have to talk about in terms of background information is the circadian rhythm. This is the 24-hour wake-sleep cycle that's controlled by a small structure in the brain called the suprachiasmatic nucleus. I don't know, Jennifer, if you've been able to advance to the next slide. In any event, this structure in the deep brain responds to light signals that are perceived by the retina. And these light signals entrain this gland to produce cortisol during certain phases. That's the wake up, stay awake hormone. And then transition to production of melatonin, which makes a person get sleepy and go to sleep. And disruption in the circadian rhythm can lead to sleep problems. Everyone has experienced a major disruption, which is jet lag.
Thank you.
But other areas of the brain and hormonal signaling systems also regulate sleep behavior. So all of these systems have to act together, and the cascade that sort of sends all the other areas of the brain into action to produce the hormones that are needed for sleep are triggered by this, the circadian rhythm signals. All right, still doing background so we can move into the meat of the talk. We have to define what we talk about by sleep problems. So there's a garden variety of sleep problems, which most people refer to as insomnia. And the people who study sleep, again, Jennifer, I've moved to the next slide. I'll try to get better about alerting you. The people who study sleep sort of measure specific aspects of sleep, and there you can break it down into these various features. So a prolonged sleep latency takes a long time to get to sleep. This is sort of onset insomnia. Excessive waking after sleep onset is called maintenance insomnia. This is people wake up multiple times during the night and can't really get a full night's sleep without waking up. There's short total sleep time. There's low sleep efficiency, which is a measure of hours of sleep compared to the number of hours that you spent in bed. And then there's poor sleep quality, and this is failure to reach the delta wave phase of REM, that very deep sleep that precedes REM onset. So that's sort of the general category of insomnia. Then there are certain clinical sleep disturbances that are associated with sort of physiological problems. The one that's the most common is, and most people have heard of, is obstructive sleep apnea, which is abbreviated OSA. And we'll talk much more about this in a minute. There are sleep-related movement disorders like restless leg syndrome that can interfere with sleep. And then there's something called REM sleep behavior disorder. This is acting out dreams during the REM portion of sleep. Remember, during REM, that's when dreams occur, and people with this sleep behavior disorder act out dreams, and this is associated with some cognitive impairment problems down the line. Again, we'll go into these a little bit more detail as we go on. Next slide, please. All right, so there are certain specific definitions of insomnia that researchers use. So in order for somebody to be diagnosed with insomnia, they have to have at least one sleep problem, such as difficulty falling asleep, difficulty staying asleep due to nighttime awakenings, waking up early and not being able to go back to sleep, and poor sleep quality. So they have to have at least one of these sleep problems at least 3 times per week for more than 3 months. And that's chronic insomnia. Insomnia like this causes acute functional problems such as fatigue, bad mood, and poor concentration. It is the most common sleep problem. I've seen different estimates of how frequent it is. Again, if you stick to the strict definition, the prevalence seems to be lower, but my guess is that somewhere between 10 and 40% of the population have it. I would say 20 to 30%. It's increased in the elderly. This is partly because the elderly sometimes they have a decline in melatonin production, or they may have changes in their sleep patterns when they retire. But it's very common in the elderly, and it's been linked to the risk of cognitive decline, as we'll talk about a little bit more later. So now let's talk about obstructive sleep apnea. Sometimes in the medical literature, this is called sleep disordered breathing. It occurs when the upper airway collapses, thus blocking flow of air into the lungs. And there's a picture of the collapsed airway over to your right. It often occurs during REM sleep when muscles are very relaxed. And when the airways are closed off, the blood oxygen level can decline. If it gets down low enough, this will trigger an arousal from sleep. And if this happens frequently during the night, then the person feels like they've hardly had any sleep, and they will have daytime sleepiness. And in 58% of cases of OSA, the individual has obesity. So obesity is one of the most common features of obstructive sleep apnea. So what are the health effects of OSA? So the first one is quality of life and functional capacity. So people with OSA almost always complain of excessive daytime sleepiness and fatigue, and this often will take them to the doctor. They may have cognitive problems like poor concentration and slowed reaction time, and they may have mood problems such as depression and irritability. Severe OSA during REM sleep is associated with worse diabetes control and the risk of developing hypertension. So studies have shown that people with severe OSA, that this condition leads to worse diabetes control. Their blood sugar is more difficult to control, and other studies have shown that it can trigger development of hypertension. OSA is strongly associated with risk of heart attack or stroke, but many studies don't establish that the OSA is causing the event. Since so many people with OSA also have cardiovascular risk factors, it's a little bit difficult to tease out whether the increased risk of heart attack or stroke in people with OSA is just because OSA occurs in people with these risk factors. But there are some studies that kind of tease out this cause-effect situation to elucidate it. In a large prospective study, severe OSA, which was defined as more than 30 episodes where the blood oxygen saturation went to less than 90%. So severe OSA, but not mild or moderate OSA, was associated with reoccurrence of heart disease. That is a new heart attack, a new transient ischemic attack in persons who had existing disease. However, there was no association between any severity of OSA and cardiovascular events in persons without pre-existing heart disease. So this was an important paper that showed that yes, in people who have heart disease, if you don't address OSA, it can lead to worsening heart disease. But it's not clear whether OSA contributes to a new case of a heart attack, shall we say. In another study that used the same cohort, severe OSA was associated with increased number of deaths in men 40 to 70 years old. That is, deaths from any cause, but not in older men or women of any age. So these careful studies show us that yes, OSA is a risk factor for death and a risk factor for worsening cardiovascular disease in certain groups of people. And since it does seem to initiate some of these cardiovascular risk factors upstream, it may contribute to the development of heart disease. All right, moving on to the next slide. So what about obstructive sleep apnea and other sleep disturbances and the risk of cognitive decline and Alzheimer's disease? Again, we turn to the medical literature just to answer this question. There was a pooled analysis of 6 population-based prospective studies. That means that people, sort of a random sample of the population, was followed from an early point to look to see whether those with OSA developed cognitive impairment. So the cause was documented to precede the effect. So in this pooled analysis, there was a 26% increased risk of cognitive impairment in persons with obstructive sleep apnea. In this study, it was called sleep disordered breathing, as I mentioned earlier. In another pooled analysis of multiple studies, people with sleep problems, including obstructive sleep apnea, had a 68% increased risk of cognitive impairment or Alzheimer's disease. And in this study, they considered not only sleep apnea, but other types of sleep problems like insomnia. The authors estimated 15% of Alzheimer's disease cases in the population could be linked to sleep problems. So why do sleep disturbances lead to cognitive impairment? So again, we wrestle with, what's the cause, what's the effect? For sleep problems that are classified as insomnia, the causal link is not clear. So sleep problems may be a symptom of an underlying neurodegenerative process. Like that's an early symptom, say, of a developing cognitive impairment. However, multiple studies show that beta amyloid clearance, beta amyloid is the protein that accumulates in the brain of people with Alzheimer's disease, and is thought to be part of the pathological process and is required for a person with dementia to be classified as having Alzheimer's disease. So this protein is cleared from the brain during sleep, and the clearance follows a circadian pattern, which is highest during sleep. So the theory is that people who have disturbed sleep or don't get enough sleep have accumulation of beta amyloid in the brain that can sort of trigger this pathological process that ends up in Alzheimer's disease. In the case of obstructive sleep apnea, studies suggest that repeated episodes of low oxygen saturation trigger harmful processes in the brain. That is, just the fact that there are these periods where no oxygen is getting to the brain causes damage, and it leads to vascular dysfunction, that is, the blood vessels in the brain don't function properly. It could lead to neuronal death, and it might trigger increased beta amyloid production. All right, so those are the health effects of these common sleep disturbances, obstructive sleep apnea and insomnia. So what can you do to make sure that you keep a healthy level of sleep? If you're lucky enough to be healthy and you want to avoid chronic disease development, cardiovascular disease, as we know, is a risk factor for dementia. And of course, we all place a high priority on preventing cognitive decline in dementia. So the common recommendations that everyone's probably heard, if you go to your doctor, you get these, we're going to review these, and I reviewed sort of a critical analysis of these common recommendations to see which ones have the most support for efficacy. So avoid caffeine. What is the evidence that this will actually take care of a sleep problem? So the evidence that caffeine disrupts sleep only applies to situations where the caffeine is consumed right before bedtime. It's not clear if avoiding caffeine earlier in the day is going to correct a sleep problem. So if you know you're sensitive to caffeine and you know it messes up your sleep, then by all means avoid it. But if you present with a sleep problem and you're not sure what it is, the doctor says, well, get rid of all your caffeine. You could try that. And it's not clear that, other than avoiding it right before bedtime, that that's going to take care of the problem. Avoid nicotine. So nicotine disrupts sleep, but it's unclear if smoking cessation improves sleep. It stands to reason because nicotine disrupts sleep, but there's not experimental evidence that people who smoke will have improvement in their sleep problems if they stop smoking. The next recommendation, avoid alcohol. Again, acute alcohol administration before bed disrupts sleep cycles, but it's unclear if small doses cause problems. And sleep problems persist in alcohol-dependent persons who stop drinking. So again, it's a very common advice because studies have shown that people who drink right before bed have problems with sleep. What's not so clear is that if you completely cut out alcohol, particularly if you're dependent on alcohol, if that's going to correct the sleep problems. All right, more recommendations. Exercise regularly. So there is significant evidence that exercise improves sleep. And furthermore, there's no evidence that late night exercise disrupts sleep. In the sleep hygiene recommendations that I have seen in many, many places, the advice to exercise regularly goes with, but don't do it just before bed or don't do it late at night. This is based on some hypotheses about what the exercise will do to those hormonal systems that I mentioned that control sleep. It turns out that there's really no basis for making that recommendation. It just seems that exercise in general improves sleep. Manage stress. This is a recommendation that comes with very little guidance on how to do this. It's sort of left up to the individual to figure it out, and you get recommendations about mindfulness and yoga and maybe changing jobs. But each person has to figure out how to implement this recommendation, and so there's not a lot of solid evidence that stress management techniques actually cure health problems. Another piece of advice: reduce bedroom noise. This actually has extensive experimental evidence that it works. So that's one that goes with a gold star for efficacy. Make sure you go to bed at the same time and wake up at the same time. This is again based on the reasoning that you need to keep your circadian rhythm in good order, and that disruptions cause disruptions in the sleep cycles. But this advice does not have experimental evidence to support the efficacy. And it's just, again, based on what makes sense to people who study sleep. And if it works for you, then that's great. Avoid daytime naps. That's another piece of advice on the list that you get from your doctor or other public health people. Again, no evidence that daytime naps interfere significantly with sleep. So that is the list of common advice that's given for people who have sleep problems that are, thought to be due to insomnia. There was this critical review that examined how effective these might be in actually helping people get over their sleep problems. And the basic bottom line message from this review was that we really need more research on what actually works. So let's talk a little bit now about melatonin. I'm moving on to the melatonin slide, Jennifer. So as we saw earlier, melatonin serves as a time cue to the biological clock. It sort of sets that timing for the clock. In experiments of giving melatonin to people who have sleep problems, it's shown that taking melatonin a couple of hours before bed reduces sleep latency by an average of 6 minutes. So that's the amount of time between when you go to bed and that you actually fall asleep. It does not increase overall sleep time. It has few side effects with a low dose and short-term use, and short-term is defined less than 3 months. And it's considered first-line treatment for insomnia and much preferable to drugs like benzodiazepines and other classes of drugs that can have undesirable side effects. It's particularly favored in the elderly because benzodiazepine use is associated with falls and all sorts of other problems. So melatonin can be used if you're going for sleep time regularity and you need to get to bed earlier because you need to get more sleep. Melatonin can be a good strategy because it does make it easier to fall asleep earlier. So we just covered the sort of general sleep hygiene advice and the use of melatonin for treating insomnia kind of sleep problems. Now let's talk about treatment of obstructive sleep apnea. So OSA is suspected in people who complain of excessive daytime sleepiness and or other sleep problems. Sometimes it'll be just diagnosed on the basis that the person is obese and complains of excessive daytime sleepiness, and it's just assumed that they have obstructive sleep apnea. But really, the definitive diagnosis is done with an overnight sleep study where all of these parameters are measured. The airway obstruction, the sleep cycles, the number of awakenings, and so forth. The treatment of obstructive sleep apnea is to correct the airway obstruction that leads to oxygen desaturation in the blood. So everyone's heard of CPAPs. These are mechanical devices to keep the airways open. Unfortunately, adherence to these devices is poor. Many people find them uncomfortable and can't really tolerate them. You can try sleeping at an elevated angle to make it, so that it's a little bit more difficult for your throat to collapse. Many clinicians will want to rule out obstructive sleep apnea before treating a sleep disturbance with prescription sleeping pills or other, or maybe medication to keep people awake during the day. And this is because obstructive sleep apnea is so closely related to these chronic health conditions and mortality in certain groups. If somebody's having obstructive sleep apnea, you don't want to depress their breathing more with sleeping pills. Next slide, Jennifer. Okay, moving on to, I wanted to cover REM sleep behavior disorder a little bit because, I work in the Alzheimer's and other dementia setting, and this is not a common disorder, but it can have very significant health implications. So as we said earlier, dreams are acted out during REM sleep. The person flails their arms, there can be shouting, kicking. The dreams typically are sort of an aggressive or very disturbed nature, involving chases and so forth. The individual or the bed partner can be injured during these episodes. REM sleep behavior disorder usually begins in the 5th or 6th decade of life, but can begin earlier. There's increased frequency in persons who are treated with antidepressants or who have a psychiatric diagnosis. But beyond that, the REM sleep behavior disorder is strongly associated with Lewy body dementia and Parkinson's disease. Both of these neurological disorders have the same pathological cause. They're caused by a buildup of alpha-synuclein in brain cells. And this REM sleep behavior disorder may precede the development of symptoms by several years. So it's a good idea to, if you are experiencing this or someone you are close to is experiencing this, it's a good idea to get it evaluated and documented. Because sometimes if cognitive impairment begins, dementia with Lewy body usually begins with cognitive impairment before there's any movement disorder. And the best way to be able to diagnose dementia with Lewy bodies is with a history of REM sleep behavior disorder. Treatment includes measures to prevent injury, treatment of obstructive sleep apnea if that's present, melatonin and or clonazepam also can be given to treat it. All right, moving along. I'm on the next slide. Sleep disturbances in Alzheimer's disease. These are very common. They occur in about 45% of persons with AD. They involve all sorts of sleep disruption, fragmented sleep, altered circadian rest or activity patterns. People get up in the middle of the night and get ready to go out and so forth. The causes are thought to be related to the patterns of neurodegeneration. In other words, which areas of the brain are affected by Alzheimer's pathology and disrupt the neuronal networks that are conveying the signals that regulate sleep. The sleep disorders in Alzheimer's can cause significant distress to the caretaker and other family members. The treatment involves addressing obstructive sleep apnea if present, institution of safety measures to prevent eloping, that is, the person gets up and leaves the house in the middle of the night, or injuries. Careful management with pharmacologic agents can be instituted if the clinician thinks it's necessary to maintain the well-being of the patient and the family members. The literature on the effectiveness of melatonin for the sleep disturbances in Alzheimer's is limited. There is not good experimental evidence that it corrects sleep pattern problems, but clinicians may try it anyway to see if they can get it to work because it has so few side effects. And then the go-to pharmacological agent to treat these sleep disturbances is trazodone, which is an antidepressant. But it works really well for these sleep disturbances in Alzheimer's disease. It improves sleep quality, which means, you know, the sleep cycles, the person cycles through the appropriate stages of sleep. And there is some evidence that it can improve cognition. All right. Getting to the end of the talk here, I'm on the last slide, summary and takeaway points. Excuse me. Sleep problems are very common, and they can interfere significantly with quality of life and productivity. This is in people at all ages. Some sleep problems, particularly obstructive sleep apnea, can lead to or aggravate serious health conditions, including hypertension, diabetes, and heart and other vascular diseases. There is good evidence that sleep disturbances increase the risk of cognitive impairment and Alzheimer's disease, and the prospective studies support a causal association. Research on effective non-pharmacologic treatments of sleep disturbances is lacking. In other words, we don't know if the advice that most people get to treat sleep problems without taking drugs is actually going to work. Correction of sleep disturbances may be an effective way to prevent dementia, but this intervention has not been tested prospectively. And finally, the last slide, the summary and takeaway points continued. Actions that have the best supportive evidence of benefit are getting 7 to 8 hours of sleep a night, because less than 7 and more than 8 are associated with cognitive problems. But again, there's variability around averages, and in general, quality of sleep is more important than quantity. In other words, being able to have a sleep architecture that goes through the cycles of sleep, including deep sleep and REM sleep, that result in feeling rested and awake the rest of the day. Reduce bedroom noise to prevent sleep interruptions. Exercise more, doesn't matter if it's just before bed. If you think you have OSA, it's good to get it diagnosed and manage it if it's present. It's uncomfortable, but wear your CPAP or any other device that is more comfortable that you can stand to wear. And then of the other possibilities, any measure that seems to work for you. I think if you want to address a sleep issue, you'll have to experiment with all the possibilities that you've heard about and see which one actually works. And try melatonin. It has very few side effects. It's got many physiological benefits aside from sleep. But keep in mind that it's going to mostly it's going to address your ability to get to sleep when you get to bed. And that in itself can help with regulating the overall circadian rhythm. All right, so I'm finished, and I'll turn it back over to Jennifer, and she can moderate whatever rest of the session there is.
Okay, thank you, Dr. Pavlik. That was very informative, and certainly, I think for me, highlighted the importance of getting good sleep, and if you're not, to figure out how to correct that. We did have a few questions come in during your talk. So one of our participants wanted to know if you could recommend a dose of melatonin. If there's one that you should start with if you're going to try that.
I've seen the dose 3 milligrams. So I would start with the lowest dose and work up. And there are also again, since I'm not a sleep doctor, I don't usually do this. But in the papers I read, there are also time release melatonin, which for some people may be helpful. But I think I recommend the lowest dose and see how that works, and then double it. And remember that since you probably will get it at the drugstore, see what the label recommends, but that the dosage should remain fairly low. So if it doesn't seem to work for you, don't keep increasing the dose. The lowest dose or the next level of dose should be effective. That doesn't work, then this melatonin doesn't work for you. It's interesting that in the clinical population here, when we review cases and in our weekly conferences, the Alzheimer's specialist here starts with melatonin for almost every sleep problem, just to see if it will work. And sometimes it works, and then sometimes it doesn't. People will come back and say, I tried and it just didn't work. So try the low dose. Go to the next dose, and if that doesn't work, you probably will need another strategy.
Okay, thank you. Another question came through. One of our participants wondered about nutrition and was curious that wasn't mentioned.
I've thought about putting that, trying to address that in the talk. I have not seen any scientific reports on this. It's a deep dive because, it's the nutritional literature, but I have seen media reports of people who don't eat before bed. If you cut out your evening meal, this is sort of an intermittent fasting strategy where you don't eat anything after 5 o'clock at night. They report correction of sleep problems. I've tried that myself, and I found that it works really well. And there are also advice that's sort of part of the sleep hygiene, but was not on any list that I found in the literature, is to not eat a big meal before you go to bed. So I think correcting GERD, if you have GERD, that will wake you up. And again, it's something that can be tried. If you're awakened with sort of indigestion all the time, that's probably, need an antacid and maybe need to eat different things before you go to bed.
Mm-hmm. So I guess that would fall under the category of things you could try and see if they work.
Absolutely. Yeah, absolutely. Yes. Again, it hasn't made it onto a list of official recommendations. Mm-hmm. The ones that are on the CDC website and in, the strategy of every sleep doctor or sleep therapist. But it's certainly, I think it's an oversight. It probably is, is a gap in the advice that's available. Because I do think that the dietary habits are very involved in the quality of sleep during the night.
Back to melatonin, we had one of our participants mention that they had tried melatonin and found that they had terrible nightmares. Is that a common side effect that you're aware of?
Again, it probably altered their sleep cycle so that their REM sleep got kind of weird. Theoretically shouldn't alter sleep cycles, but if the person has gone to bed at a different time than usual, that's not part of their usual sleep cycling, that could happen. I haven't heard of it. So yeah, it's an adverse effect. I would not, doesn't work for this person. Hello?
Hello, we've lost sound.
Yeah,
Okay.
I'm still on. We've lost Jennifer, I think.
Okay, it looks like maybe we did. This is Julie. I will pitch in. We have another question, Dr. Pavlik, and it's asking, does it make sense to measure one's blood oxygen levels before bed or after wake up?
I would say no, because when you're awake, you will have restored the episodes of hypoxia.
Got it.
The problem with obstructive sleep apnea is that your blood oxygen goes down while you're asleep, and then if it gets low enough to trigger your sort of arousal to make you take a deep breath, then by the time you get around to measuring your blood oxygen, it may have been restored. So if you really, I suppose you could wear a pulse oximeter all during the night and check it at the moment that you are aroused from sleep. You might see that it's lower, but it has to be below 90% to wake you up. But again, it's always best to if you're worried about obstructive sleep apnea, that's the one where it's really worth having a sleep study and documenting it.
Sure.
Because the sleep study will also tell you how severe it is. You know, in all of the literature that I've seen, it's really the worst effects are in people who have severe sleep apnea. And that's graded by the number of episodes that occur where the blood oxygen saturation goes below this certain level. And so if you have mild sleep apnea, you know, it may make you feel groggy during the day, but it doesn't have those really severe health effects like, you know, disruptions in blood sugar control or the risk of heart attack or all-cause mortality.
Okay, thank you. Excuse me, we do have another question coming through. Is there any evidence that correcting thyroid problems that affect sleep would be helpful?
Yes. I mean, I would say that would be something that would be part of the, you know, yes, I think so.
Thank
Thyroid
you.
problems can either, you know, if it's low, you're going to be sleepy, and it'll interfere with your signaling processes. Again, there are these elaborate systems that communicate with each other in the body, and thyroid hormone is certainly one of them. So yes.
Great, thank you. Okay, so as we are wrapping up here, I know we're getting towards the end. If there's any other questions that people have, please feel free to use the chat function and send that in. If we don't get to it right away today, we can always follow up. But Dr. Pavlik, if there were two things that you would recommend that people can do right away with whatever resources they have at home or you know, easily accessible, what are two of the best ways that people can do to improve either their quality of sleep or how they sleep for brain health?
So the number one thing I would recommend is exercise.
Great.
And number two is it's more of a, you know, it's not just one thing, but it's looking at doing a careful examination of when you go to bed, what you do when you're in bed, what it is that wakes you up at night. Again, it may be, maybe you realize that it's the food you were eating. Maybe you realize that there's loud traffic sounds, you know, that are interrupting your sleep. I think a self-assessment of what it is that causes you to wake up so that you can try one of these methods here that we've suggested.
Great. Thank you. So Jennifer has put back up our map, and we just want to, again, thank Dr. Pavlik very much for her presentation. I think we've all learned something here today about how improving our quality and quantity of sleep and what we do leading up to that can help improve our brain health as we try every day to do things to stay healthy in body and mind. But what we also want to remind everybody that while we're trying to do lifestyle adjustments and accommodations to improve our brain health, there's other ways we can also fight Alzheimer's disease, and one of those easy ways is by participating in a clinical trial. We have lots of trials going on with lots of different kinds of requirements and accessibility, but there's probably one near you. We invite you to go to globalalsplatform.org. The URL is up on the screen here and probably in some of the emails you've received. It certainly will be in the follow-up evaluation, but you can go there and click on your state, your zip code, and find one of our great, friendly, clean, safe GAPNet sites near you and learn about what's going on and how you can help and volunteer. Again, as Jennifer said at the beginning of the call, we thank you for being part of this. We encourage you to complete your evaluation. You will also receive some resources and a link to this presentation when it is available. So thanks again, and hopefully we'll catch you on the next GAP Talk.
Thank you, Dr. Pavlik. This is John Dwyer. Just wanted to echo Julie's remarks.
Thank you.
Thank you, everybody, and have a great day.
Thank you.